Good evening, sir.
Good evening,
Today
respected
topic
professor, sir. Yeah, good evening, respected professor, sir, and my dear students. I welcome you on to another session of DNB online academic activities by RAISA on Webex platform. Today we have some important and recently often asked questions. I hand over the session to professor and students. Over to professor and students, please.
Good evening, sir. Today topic for presentation is anesthesia for cytoreductive surgery in a 40-year-old female with ovarian cancer. Cytoreductive surgery is a technique where visible or macroscopic tumor is removed, which also involves organ removal. IPEC, which is hypothermic intraperitoneal chemotherapy, is a technique where infused chemotherapy, which is heated to 42 to 43 degrees Celsius into the peritoneal cavity. It is performed following the extensive cytoreductive surgery. In certain malignancies, it is associated with an improvement in median 5-year survival rate. And this technique leads to extensive physiological and potential pathological changes, which causes the implications for perioperative care. And regarding the pathophysiology, the hyperthermia, where the chemotherapeutic agents are heated to 41 to 43 degrees Celsius, which causes selective debulking or destruction of the malignant cells by reversible non-selective inhibition of RNA, which causes mitosis arrest in malignant cells, which in turn causes the increased tissue penetration of the drug, leading to vascular stasis in the microcirculation in the malignant tumor, which in turn causes anaerobic glycolysis acidosis, which activates the lysosomal enzymes and causes the accelerated death of malignant cells. EAT plus cytoreduction of malignant cells, which has a synergistic action which causes increased uptake. Regarding the surgical indications for IPEC and CRS, peritoneal carcinomatosis from colorectal, gastric, ovarian, and appendicular tumors, pseudomyxoma peritoneal, peritoneal mesothelioma, low volume peritoneal seeding from GIT tumors, and perforated gastrointestinal tumors.
Your audio is not working, Dr. Ranjani.
Appropriate selection of patients is needed to achieve complete cytoreduction, which is the key for the successful outcome. Medical optimization with no active cardiac and respiratory disease as per the American Heart Association guidelines on perioperative severe evaluation and care for non-cardiac surgery. Other criteria are absence of extra-abdominal disease or significant retroperitoneal disease, extensive hepatic metastasis, age less than 70 years, and peritoneal disease that is amenable to complete or near complete resection. And regarding the pre-op assessment, which is prehabilitation, which enhances the functional capacity of the patient and improve the exercise tolerance, which can be done by clinical investigations like chest X-ray, ECG, pulmonary function test, and ABG. And the cardiac risk assessment should be done, which is similar to the risk for any other abdominal surgery. As the cytoreductive surgery and IPEC is a major surgery, and echo should be done, and other dynamic cardiac assessments should be done, and full blood count, coagulation studies, electrolyte, urea, and creatinine levels to be measured. And thorough assessment of cardiac and pulmonary systems is necessary because it is very important to assess their ability to respond to the physiological challenges facing intraoperatively. Review the nutritional status of the patient preoperatively and obtain a pre-op albumin level. Since there will be a lot of fluid shift and patients are susceptible to hypoalbuminemia. And estimation of GFR is important, which helps to identify patients at risk of acute kidney injury associated with IPEC. And regarding the surgical techniques, there are three techniques, which is exploration, cytoreduction or debulking, and chemoperfusion. Regarding the exploration, the exploratory laparoscopy is performed to assess for disease progression or proceed directly by opening the abdomen through full-length midline laparotomy incision and to evaluate the peritoneal cancer. And regarding cytoreduction or debulking, the surgeon will remove the macroscopic or visible tumor, which also involves the organ removal. Chemoperfusion, here the abdominal cavity is rinsed with a heated chemotherapy solution. Cytoreductive surgery, which is ranges from isolated omentectomy to complete resection of multiple abdominal organs like gastrointestinal tract, pancreas, liver portions, spleen, uterus, ovaries, gallbladder, and peritonectomy, which is commonly performed, which is associated with increased intraoperative blood loss. HIPEC can be delivered in one of two ways, which is the open or Coliseum technique or closed technique. Regarding the open technique, there is an optimal distribution of heat and cytotoxic solution due to manual steering of abdominal contents. But this technique has its own disadvantages due to increased heat loss, which requires an increase in temperature of the perfusion fluid, exposing the bowel to risk of scald injuries, which also causes the spillage of the cytotoxic drugs, and there is also suboptimal exposure of anterior parietal wall. And other technique is the closed technique, which avoids the disadvantages in open technique, which prevents the heat loss and minimizes the drug spillage, but it causes increased drug penetration, but homogeneous distribution of perfusion fluid cannot be achieved. And regarding the physiological changes during HIPEC, there will be cardiovascular changes, respiratory changes, renal and coagulation changes. Regarding the cardiovascular changes, there will be increase in heart rate and central venous pressure, and there will be no significant change in BP. And regarding the respiratory changes, there will be increase in peak airway pressures and increase in EtCO2 levels, and there will be decrease in PO2 or FiO2 ratio. And regarding renal, there will be decreased perfusion to kidneys, which also causes metabolic acidosis and increased lactate. Coagulation, in the cytoreductive phase, there will be hypothermia, and in the HIPEC phase, there will be hyperthermia, which and associated coagulopathy will be present, which causes decreased platelet count and increased prothrombin and INR. And regarding intraop management, the main goals are fluid management, hemodynamic management, coagulation management, and temperature management. And regarding fluid management, regarding the cytoreductive phase, there will be extensive debulking surgery, so significant blood loss and evaporative losses will be related to due to the open abdomen. And HIPEC causes the peritoneal inflammation, which causes perioperative third stage losses. Cardiac output monitoring, pulse pressure variation monitoring, and urine output should be monitored, and point of care testing like Rotem and TEC should be followed, which is helpful in maintaining the hemodynamics and fluid balance. And fluid replacement with crystalloid or colloid solutions and blood and plasma should be done. And a restrictive and liberal fluid replacement, it depends on the situation. Large fluid shift, which is associated with cytoreductive surgery. So it is necessary to provide a fluid regimen which maintains the systemic and regional perfusion. Regarding the hemodynamic management, maintenance of end organ perfusion is important. Therapeutic agents which causes increase in body temperature, which in turn leads to dilation of peripheral vasculature, which causes increase in heart rate in order to maintain the cardiac output. Closed technique is associated with increase in peak airway pressure and central venous pressure due to increased intra-abdominal pressure. This cytoreductive surgery in HIPEC has similar effects of pneumoperitoneum due to filling of abdomen with saline chemotherapy. And more standard monitoring techniques like arterial line, central line, and urinary catheter should be done. And more higher techniques like transesophageal echo is not recommended. Central venous pressure is not an accurate representation of patient's preload status as it increases the intra-abdominal pressure. A very useful technique is to guide the fluid status in proper stroke volume variation, and other special monitors like flow track and Vigilo systems are also useful to measure the cardiac output, stroke volume, and ejection fraction. And coagulation management, cytoreductive surgery and IPEC is associated with significant coagulopathy, which requires the transfusion of plasma products in 1/3 of patients. And coagulopathy is associated with the disease severity based on the peritoneal carcinomatosis index. And lab tests should be done, that is PT, coagulation studies, PT, PDT, INR, and tranexamic acid, which reduces the requirement of transfusion of red cells during the cytoreductive surgery. And restrictive transfusion policy is adopted since in surgical oncology, blood transfusions are associated with increased morbidity. And regarding the temperature management, for cytoreductive surgery and IPEC is associated with both hypo and hypothermia. During cytoreductive phase, there is increased risk of hypothermia due to extensive debulking and large area of surgical procedure. And hypothermia in turn increases the risk of blood loss and surgical wound infection, and which alters the pharmacokinetics of commonly used anesthetic drugs. And efforts to be made to prevent the hypothermia, like warm fluids, forced air warmers, and warming blankets, and monitoring the patient temperature and room temperature, and ensure the patient remains the normothermic. And prior to commencement of intraperitoneal chemotherapy, controlled hypothermia should be started by changing to cool IV fluids and decreasing room temperature in anticipation of chemotherapy, which in turn leads to hypothermia. And the sites of temperature probe monitoring, the temperature probes are placed on multiple sites in abdominal cavity, where the key sites are supradiaphragmatic area, lesser sac, and pelvic cavity, and near the root of mesentery and between the bowel lobes. And core temperature is maintained by keeping the temperature probe at the esophagus and the abdominal cavity. The thermostats are placed. And the carrier solution for IPEC, which is heated to 42 to 43 degrees Celsius, which in turn the body temperature will rise to 40.5 degrees Celsius, and hypothermia in the IPEC phase, which increases the systemic oxygen demand, which causes the increased metabolic demand and raised ATCO2 levels, which causes metabolic acidosis. Hypothermia, increased risk of coagulopathies, liver dysfunction, renal dysfunction, neuropathies, and seizures. During the entire phase, urine output should be maintained. In the cytoreductive phase is 0.5 ml per kg per hour, and IPEC phase 2 to 4 ml per kg per hour, and in the post-IPEC phase 1 to 2 ml per kg. And electrolyte disturbances are important, especially calcium, magnesium, and potassium, and it should be replaced if required. The role of regional anesthesia, intra and post-op pain management is important, especially it is done with epidural anesthesia. A well-functioning epidural, it decreases the need for both post-op and intra-op opioids. As this cytoreductive surgery and IPEC is a very painful procedure, and with pain scores similar to the or more than that of thoracotomy. And patients who are already on complex anesthesia regime, we can also adopt a patient-controlled epidural analgesia as a useful adjunct, as this decreases the ventilator support and the opioid-sparing effects of an epidural, which causes the decreased instance of bowel dysfunction and atony. And regarding the chemotherapeutic considerations, depositing the chemotherapy in the peritoneal cavity requires the higher doses to be used than used systematically, which increases the cell permeability and metabolic activity and causes the tumoricidal effects. And side effects associated with chemotherapeutic agents, the anesthetist should be aware of. Most common allergic reactions, flushing, nausea, and vomiting, and cardiotoxic effects of chemotherapeutic agents like cisplatin, which causes prolongation of QT interval, and some reports of pulseless ventricular tachycardia. And also cisplatin causes nephrotoxicity, and there is a need to prevent renal injury. And mitomycin C and doxorubicin associated with neurotoxicity and myelotoxicity. And regarding the safety measures in the theater, use of chemotherapeutic agents in OT poses a risk to the theater staff. Personal exposure may arise from different routes like air contamination, contact contamination, and also from pulmonary absorption or manipulation of tissues or objects to certain chemotherapeutic agents. Body fluid should be chemotherapy contaminated for 48 hours. With the open technique, the cavity is covered by a plastic sheet to minimize the exposure and a smoke evacuator under the sheets to minimize the vapor contamination. And closed technique offers a high level of protection compared to the open technique for the operators. Education of the OT personnel is must, and regarding the use of chemotherapeutic agents which minimize the risk. Routine medical surveillance of personnel should be done by routine checking of blood test and the monitoring of any adverse reactions. Ambient air and biological monitoring should be done, and standard safety and chemotherapeutic handling protocols should be adhered to, and use of personal protective equipments and avoidance of any spillage of cytotoxic drugs, and careful handling of chemotherapy by trained personnel. Appropriate personal protective equipment should be used by all personnel, like face mask, gloves, protective gowns, and overshoes. Filtering mask should be changed every 2 hours, and double gloving methods and wearing gloves for no more than 30 minutes is recommended, and goggles should be worn to protect eyes from splashes, and air conditioning should be continuous throughout the surgical operations, and AC filters should be of high efficiency particulate airtights, and doors should be closed with appropriate note. And mainly we have to monitor the hemodynamics, and thrombocytopenia is more common due to coagulopathy, and electrolyte imbalance due to significant fluid shift. Multimodal analgesia is important, and early ambulation and DVT prophylaxis, stress ulcer prophylaxis, and early enteral feeding or nutrition is recommended, as nutrition improves the wound healing and improve the intestinal transit, and respiratory support. Intensive spirometry should be done, and infection control with appropriate antibiotics, and careful fluid management and balance is important, as vasodilation is most common after IPEC. Vasopressors can be instituted, and we have to avoid large fluid volume resuscitation where patients are not fluid responsive. And regarding complications of surgery, as with all major abdominal surgery, there are increased risk of bowel perforation, anastomotic leakage, postoperative bleeding, infections, and fistula formation and bile leakage, and venous thromboembolic complications. And postoperative ileus is also most common. Abdominal complications with chemotherapy, which causes transient leukopenia with dearranged transient transaminases, which have impact on surgical complications. Thank you, sir.
Okay. It was a very exhaustive presentation. But can you read the question that is given, please?
Anesthesia for cytoreductive surgery in 40-year-old females, sir.
Female with what is the diagnosis given
Over
there? CA ovary. Okay.
CA over, yes, sir.
Right. Is there any mention about HIPEC there?
No,
is there
sir.
any wording as HIPEC in that question?
No, sir.
No. Okay. So HIPEC need not be always continued along with cytoreductive surgery. There can be isolated cytoreductive surgery alone without doing HIPEC in all the cases. Have you ever seen a case like this, cytoreductive surgery being done in your short training?
In combination with IPAC only, sir. So in combined with IPAC only, I've shown, sir, not a single.
I don't hear you properly. Combined with what?
A cytoreductive surgery in IPAC only I've seen, sir, not as a single.
Have you ever seen HIPAC also being done along with cytoreductive surgery?
Yes, sir.
Okay. So what was the duration of the procedure?
It totally around 8 hours, sir.
So it's a prolonged procedure, 5
Yes,
to
sir.
15 hours it may take.
Yes,
So
sir, 8 to 10 hours.
at that time, one of the important things is about taking care of the pressure points because patient is going to lie in the supine position for such a long period. Okay. But usually what happens is, earlier, what was the indication for cytoreductive surgery? See, if you trace the history of cancer ovary or cancer, colorectal cancer, or as you say, PMP, all these things were earlier thought they were all inoperable cases, especially when the stage is 2, 3, or 4. Earlier, they used to just depend only on chemo and radiotherapy. They used to say there is no indication for any surgery. But after 1980s only, they have started thinking of removing whatever visibly seen secondaries are there that can be removed, even if the primary is elsewhere. And if you have a peritoneal deposits, or you have a omental deposit, or you have a bowel deposit, all the visible tumors can be removed so that the subsequent treatment with chemotherapy, which was parenterally given, will be quite effective in controlling or reducing the intensity of the spread of the disease. That was the idea with which cytoreductive surgery was introduced. Then, instead of giving the chemotherapy parenterally, they thought it can be put into the site of the lesions which are present, which are visible, to remove the micro deposits which could have happened. They thought they can put the chemotherapeutic agent at a high temperature peritoneally and leave it there for say 45 minutes to 60 minutes and then drain them out, which they found will be more effective in reducing the micro deposits also than the macro deposits which are visibly seen. But gradually, this procedure of cytoreductive surgery, or as you say, debulking, has been advanced to even first stage where the cancer is diagnosed and there are a few peritoneal deposits alone, not spread to other organs like spleen, liver, or intestines. Even for that, they wanted to do that. So in such situations, first thing is to confirm that it is a malignant tumor. Okay. So the biopsy is very important. What are all the markers to say? Here the case scenario is given to a specific cancer. It is not a generalized term to say cytoreductive surgery. Here the 40-year-old female is given, CA ovary is given, so the diagnosis is made. So what are the indicators or biomarkers to say patient is suffering from CA ovary? Is there any blood biomarker?
CA 19.9, sir.
CA 125. Okay.
120.
So CA 99, 19 and all, it's of course most of them are the cancer markers. What is the CA 125? It's cancer antigen 125, which means it's nothing but a protein which increases. And normal value should be less than 100, but in cases where it is an advanced or even early cancer, it may be several folds more than the normal value. It may be 1,500, 2,000 to 3,000. Recently, I had a patient coming from southern districts who had a CA 120 of 10,500. And peritoneal fluid aspiration and cytology also will show the malignant cells getting deposited into the peritoneal fluid along with the peritoneal deposits. So in such patients where HIPEC is not indicated and only cytoreductive surgery is planned, even in the early stages, they do this procedure, and that starts like this. First they want to confirm the diagnosis, because the blood marker CA125 can be increased in other non-cancerous conditions also. Do you know what are the non-cancerous conditions which can raise the CA125? Endometriosis or fibroid uterus. Okay, so even these conditions which are related to the gynecological conditions, that also can raise. So first thing, they want to make the confirmation. So usually how is the planning is done is, they plan for a diagnostic laparoscopy. They first start with the diagnostic laparoscopy, visualize the entire abdomen, look for the ovarian size and tumor if it is present. Sometimes, you may have a normal sized ovary from which the malignant cells could have spread to other areas. So they first do a diagnostic lab and then pick up the visible deposits or metastases that are seen under the diagnostic laparotomy, and then pick out those tumors and send them for frozen section biopsy. So that itself, the result you get it only after about an hour to two. You have to wait. So the initial period is, this is the sequence. So patient will be under anesthesia waiting for the results. And once the confirmation of malignancy comes from the lab, pathology lab, then they decide about removing the visible deposits or metastasis. And for this, they use a scoring system. What is PCI? Have you heard of that? PCI score?
No, sir.
Peritoneal Cancer Index score. Okay, that is what is being used to decide what are all the things to be removed. So there is a calculation, just like our anatomy description. We have 9 quadrants in our abdomen, isn't it? That's what you have been taught in your basic anatomy. The epigastrium, right hypochondrium, left mitochondrium, umbilical, right flank, left flank or renal, then supraumbilical, right inguinal, left inguinal, just like that. So there are the same 9 segments are there, or quadrants are there. Along with that, other deposits in the intestines and other things. So there are total of 13 segments which are classified, and the presence of tumor in these 13 segments is given a grading of 0 to 3. So maximum you may get 13 into 3 as a score of 39, and based on that they remove the organs and the deposits found in that, and then the end result is called what is the percentage of cytoreduction that they were able to. If they are able to achieve a 0 cytoreduction, that is, they have removed all the visible deposits, that means it's a good reduction. There is no need for further HIPEC theory at this stage. And patient will then subsequently, after the cytoreductive surgery, go for regular chemotherapeutic cycles as they do for any other patient, which is parenterally given, intravenously administered in cycles of up to 6 or 12, depending upon the PET scan that is. And the important thing is a PET scan also should be done before the procedure of cytoreductive surgery to see whether there are any extra abdominal deposits elsewhere in the body. Then if that is present, then there is no point in just removing these organs by doing cytoreductive surgery. So one of the important investigation is PET scan, as well as the confirmation of the cancer by frozen section intraoperatively or by biopsy preoperatively. And then the third point you have to mention here is, sometimes, with the severe deposition elsewhere in all over the abdomen, the debulking can be done after a period of chemotherapy, and that is called the neoadjuvant therapy. you use chemotherapeutic agents to reduce the deposits and the size of the metastasis, and then proceed with the cytoreductive surgery. And these patients who receive a pre-op chemotherapy, they may have all the complications that you mentioned, which the chemotherapeutic agents can normally produce on the cardiovascular system, on the respiratory system, on the renal system. All the side effects of the chemotherapeutic agents will have to be looked after before optimizing the patient and taking up for surgery. Okay, so all the other points like fluid shifts, the coagulopathy, and the chances of renal shutdown, hypothermia is more common with cytoreductive surgery. So if the wording of HIPEC is not given in the question, then you need not waste your time on writing about HIPEC. Okay. So
Okay, sir.
HIPEC will be usually included. If supposing they say it is a cytoreductive surgery and HIPEC surgery, then you can include all the points that you want to say. But if only cytoreductive surgery is given, majority of the times it may need not follow with HIPEC also. Okay, so that is what only this difference that I would like to know, tell you. So we'll share my screen with you.
Yes, sir.